So now I want to welcome Dr. Jennifer Dimbar, who is the director of the Clinical Microbiology and Virology Laboratory at the Children's Hospital of Los Angeles and an associate professor with clinical scholar designation at the University of Southern California. Dr. Dimbar's research interests include studying the applications of rapid diagnostic in the clinical setting to determine clinical utility. She has authored more than 50 scientific peer-reviewed publications and is a frequent speaker on the topics of rapid molecular diagnostic, including its use in the diagnosis of central nervous system infections. So, welcome, Doctor.
Hi, everybody. So, I'm going to be speaking on the perspective of the laboratory and our experience with the Meningitis Encephalitis Panel from BioFire. Okay, so the objectives for this talk, I'm going to be discussing the utilization of the FilmArray ME panel in our institution, discuss the potential clinical and economic impact. And then lastly, I'm going to be just introducing how the laboratories can potentially use the BioFire Syndromic Trends tool, and so I'll mention that near the end. Here in my disclosure. So as the previous speaker mentioned, meningitis and encephalitis is a huge significant cause of morbidity and mortality. There are infectious causes that includes bacteria, viruses, fungus, and parasites, but there are also non-infectious causes where it's important to be able to rule out one versus the other, such as cancer, autoimmunity, etc. The majority of the mortality that is associated with meningitis is due to an infectious cause, but the severity, of course, of the disease can be very dependent on the etiology, which is why it's important to identify the cause of the infection. Complications was mentioned by the previous speaker, so it's listed here. An example of that is even just with infants with group B streptococcus meningitis, where about 32% will have some sort of neurological, neurodevelopmental impairment even after an 18-month period. And within that group of patients, about 18% can have very severe or moderate presentation. So this is the image. The image here just demonstrates some of the different types of workup that's typically done in the laboratory. Our gold standard, as they call it, or really the imperfect gold standard, is culture, which is can be very slow, but also can be very insensitive, especially in patients that have been treated with antibiotics prior to lumbar puncture. For example, with meningococcal, the CSF can sterilize within 15 minutes after exposure to antibiotics. So, if you're performing a lumbar puncture anytime after that, the chances of recovering the organism can be very low. Gram stain, again, same thing. It's a rapid test that we do directly from the CSF, and we consider it a stat result. But it's, again, very insensitive, and it's very dependent on the organism and the burden. Other things that can be done would be the wet mounts, or India ink, as some labs still do for Cryptococcus, which again has a low sensitivity. There's lab-developed tests that are available. In the States, there are many laboratories that are that will only perform tests that are FDA cleared. So with that, there are definitely limitations, and the FilmArray ME panel is the only syndromic panel that is FDA cleared. And lastly, there are direct antigen tests that can be performed, which is also rapid, but for bacteria, it's not something that we would recommend because of low sensitivity and specificity. And for the Cryptococcus, it does have, so that's one use for it, is that it does have good sensitivity and specificity for that. Okay. This is a study that compared the culture of the CSF, culture of blood, and molecular tests for, and I chose 4 distinct targets here, Strep pneumo, Listeria, Haemophilus, and Streptococcus, which are certain targets that are part of the ME panel. And as you can see, even though there are only 222 samples that were tested by molecular compared to over 1,400 or 1,500 for CSF and blood cultures, the positivity rate is actually, it was quite high compared to culture. Even when you look at the Streptococcus species, it's significantly higher compared to culture, which just shows you, and it really proves the point that molecular test is much more sensitive. The other thing to really point out is the fact that the positivity for blood is very low. Again, just bringing home to the fact that a negative blood culture does not necessarily rule out CNS infection, as some may think. This is a panel, as was mentioned, so 14 targets total, 6 bacteria, 7 viruses, and 1 lone Cryptococcus neoformans scabbii. So what are some of the clinical benefits of the EMEA panel? Well, one thing that we found in our institution is that it really standardizes ordering practices amongst physicians. Before, there could be quite a disparity as to what is actually ordered when a patient is presenting with signs and symptoms of meningitis or encephalitis. And this study here that was published in 2016 just really summarizes that nicely with this 15 patients that's listed here. The white bar are the tests that are not ordered. The blue are the tests that were ordered that were negative, and the yellow represents the tests that were ordered that were positive. And so you can see for some patients, there was just, for example, this patient here, there was only an enterovirus PCR and an HSV PCR ordered, not culture. There's another one that had a rapid antigen test ordered, and a rapid Cryptococcus antigen test ordered without culture. So, you can see this really represents how, how the ordering practice really varied amongst clinicians. And the study also took the remnant samples from these patients and tested it on the FilmArray. And the targets that are listed here are the additional 7 targets or 7 patients that picked up some sort of pathogen that was not picked up by their conventional methods. And that included strep pneumoniae, VZV, and HSV too. So this is our data so far. So we've been live with the test since summer of 2016, so very close to the previous speaker. And we've tested almost 1,000 samples so far, with an average with about 300 or so a year. And our positivity rate is about almost 12% right now. The breakdown is 70% for viruses, which is not expected that we're going to see more viral cases of meningitis and encephalitis and bacteria. 29% for bacteria, and then, 20, I think that I can't see, sorry, 28% for bacteria, and then 2% for the fungus or Cryptococcus meningitis and encephalitis. And this is a breakdown of the different targets that we've detected so far. We've pretty much picked up every single target that's on the panel except for the Neisseria meningitidis. The biggest, most common one is Enterococcus, followed by HHV6. But we have identified a number of strep pneumoniae and even Haemophilus influenza since we've gone live. And so what we found about the panel in our first year of going live with the test is that it actually has a pretty high negative predictive value. Of the almost 300 or so patients that we've tested, only off-target positives were observed in 2 cases by culture and 3 cases by EBV PCR. Every other sample that was tested at that time was negative for any sort of target. And of the 219 patients that we looked at, 20 that were negative by the FilmArray panel were positive for an on-target pathogen from alternate sites. And that's listed here in this table. And so if you look from the top, that included a number of E. coli that were recovered from blood. CSF culture was also negative. Strep pneumonia and strep agalactose, same thing, was from blood. CSF was negative. We had a Cryptococcus that was recovered from blood, but the CSF antigen was also negative, and it was only the serum that was positive. And then a variety of enteroviruses that were picked up by NP swabs, throat swabs. And this is also the time in the summer where we were trying to rule out enterovirus D68 that was related to the acute flaccid myelitis, which is why we're seeing so many of these NP swabs and throat swabs. And then lastly, we had a number of HSV1s that were only picked up from swabs of lesions and also was negative from an alternate CSF sample. So overall, the test performed very well, and a negative was, very predictive of a negative result, even with other pathogens as well, or from other sites. So another benefit of the panel is that you really improve the diagnosis of bacterial meningitis. For our first 312 patients that we tested, 11 were positive by the EMEA panel, and only 4 of those 11 was actually positive by culture. 2 group B strep and 2 strep pneumoniae. So we picked up a good chunk that were only FilmArray positive that was diagnosed solely by that panel. And this was corroborated by another institution in Los Angeles. This is at the LA County that sees majority of adults. And they found the same thing for the first 100 patients that they tested. 7 were positive in total, and 3 of those were culture negative, including a Listeria, a strep pneumoniae, and a Cryptococcus. Another benefit that we found is that it has really improved the diagnosis of uncommon viral diseases in our case. So far, we've diagnosed 6 cases of viral meningoencephalitis, 3 of which were HHV6, 2 CMV, and 1 VZV. In all of the 6 patients, they were immunocompromised. 5 of them were, hem-onc patients or were stem cell transplant patients. 6 out of 6 had abnormal MRIs, and in all of the cases, the FilmArray EMEA panel was able to direct and guide therapy, majority of the time starting ganciclovir or acyclovir. So with that, it is very important to really correlate the clinical findings and other radiographic findings with the FilmArray panel to determine if these are true cases. So just one thing I really wanted to kind of touch on was HHV6 in general, because this is something that can come up but may not be clinically significant. So I think it's important when you do see a result to kind of pause for a minute and determine, does this really fit the clinical picture? To summarize our findings, after 971 patients, we had 24 that were positive for HHV6, so 2.5% positivity rate. And what we found for impact, apologize if this is pretty small, but basically of the 22 patients that had some sort of empiric therapy, 12 of these patients were on acyclovir, and after this FilmArray result that reported on HHV6, all 12 were discontinued. Acyclovir was discontinued on all 12 of these patients, and 5 of the 22 patients had ganciclovir started within about 13 hours. 3 of the 5 patients that had ganciclovir was actually diagnosed with HHV6 meningoencephalitis. And then the final 2, ganciclovir was stopped within about 34 hours. So overall, the majority of our patients where they felt that HHV6 did not really, fit the clinical picture, was not started on ganciclovir. So there was definitely not an overuse of antiviral therapy based on this result. And then overall discharge, as I mentioned, we had 3 that were diagnosed with meningoencephalitis caused by HHV6, but there still was a good number that were diagnosed with viral meningitis or encephalitis based on our coding system that very well could have been due to HHV6. So how can the lab really how can lab practice really benefit clinical outcomes? So with regards from the lab perspective, diagnostic stewardship is a really hot topic at this point, where you want to offer the right test, to test the right patient, and to do it at the right time. So, if you have a really fast test, but you're not doing it at the right time, where maybe you're only offering it once a day or so, is that really part of, are you maximizing diagnostic stewardship in that sense? And there's been debates about whether or not, or when you should be offering the ME panel on which patients. And I think maybe from the outsider standpoint, it may be looking like the lab is just, choosing like eeny, meeny, miny, moe, which patient gets it, which patient doesn't. One rule in general, though, is that we do not offer ME panel on any patient that doesn't have a culture ordered, and that's a mandatory requirement. So, no culture, no service, basically. One option for offering the panel, and some places may be doing this, is to offer an HSV PCR or maybe like a single target enterovirus PCR first, and if negative, reflex to FilmArray panel. But one thing that, one limitation of this is the turnaround. You're just delaying turnaround time by offering another test first. And if you're only performing the other test once a day, that just delays it even further. Another approach is to base it off of cell count. So the presence of pleocytosis. If yes, there is presence of pleocytosis, you can perform the FilmArray panel. If negative, maybe not, and you just reflex to culture. And so that's an approach that some institutions have used. We have in our institution the no restriction approach, and quite frankly, it was because we started this in 2016. There wasn't any data on it at the time. We just figured let's just try it out and see how it goes. And with the data that we collect and compile, we can determine if there's some other approach that may be better. So we base it off of the provider's order, and as long as they order the test along with culture, we will perform the PCR. Okay. And one of the reasons why we didn't restrict based on pleocytosis is due to the fact that it's not uncommon, and even just the cases that were presented in the previous talk, it's not uncommon for a patient to have meningitis or encephalitis without in the presence of an acellular, CSF sample where there's no whites at all. And it's actually been reported that patients with no CSF pleocytosis may have a higher rate of unfavorable outcome, particularly in cases of HSV meningoencephalitis, where about 8% of these patients will have an absence of pleocytosis. This is our data that we presented just recently at ECMID on 715 patients. We broke it up by viral and bacterial pathogens. And we actually only found that 59% of our patients with a viral meningitis or meningoencephalitis had pleocytosis. So the ones that did not included all of our HSV 1s and 2s, so all total 5, a number of enteroviruses, our paraechoviruses, and a number of the HHV 6s as well. And this also included 3 different bacterial targets that we would consider true bacterial infection that was also did not have pleocytosis. And when we looked at it based on age restriction, if there are some institutions that might want to restrict based on age as well as pleocytosis, we found that the presence, or the presence of less or equal to 5 white blood cells, so no pleocytosis, was pretty common for the viral infections amongst all age groups. So the less than 2-month-old, less than 12-month-old, and then greater than 12-month-old. And even for the bacteria, it was pretty common to have no pleocytosis in less than the 2-month-old, which range and be positive as well. So the data that we presented just kind of assured us that this is definitely not something that we should be restricting based on white cell counts. So can the FilmArray ME panel improve antimicrobial usage and cost? So I'm just going to present one quick case, and this was a recent case that we identified in our institution. This was a 5-day-old ex-full-term male that presents with fever and lethargy. He was hypoxic with respiratory failure that required intubation. He was acidotic, had CO2 retention up to the 50s. His urine and blood cultures were sent, as well as a HSV blood PCR that was sent. They had to delay the lumbar puncture due to the status of the patient. And at that time, they started ceftriaxone, ampicillin, and acyclovir. The lumbar trunk puncture was performed the next day, though, and they ordered culture as well as a FilmArray panel. So you can see the white blood cells were elevated. There were a number of abnormal results, elevated CRPs. His liver transaminases were elevated. The urinalysis was negative. The CSF appearance was hazy and xanthochromic. He had an pleocytosis of 5,800 cells in the whites with the lymphocytic predominance. Glucose was abnormal, less than 20, and protein was elevated. The gram stain had no organism seen, and culture was negative, which is not surprising because the patient was treated for at least a day prior. Blood cultures grew a gram-negative rod that a rapid molecular panel we reported out as E. coli. The urine culture, however, grew Listeria monocytogenes around the same time as when we identified the blood culture by culture. And then the FilmArray was also performed, and we identified Listeria monocytogenes from that. And it's interesting because it wasn't recovered from blood, but when we tested the blood broth panel on a different panel, molecular panel, we were able to identify the Listeria as well. So it's kind of interesting. He had an E. coli sepsis as well as Listeria meningitis and sepsis. So the patient was switched from ceftriaxone for meropenem for the E. coli, and then the acyclovir was discontinued within 2 hours of the FilmArray results. So just demonstrating how a result can really help and assist in stewardship. In this case alone, because the patient was on ceftriaxone prior, which Listeria monocytogenes is intrinsically resistant to, it was a great option to, it would have been, with this result, would have prompted that escalation as well, had the E. coli not been present already. One true benefit of these rapid tests is to really try to improve the use of antimicrobials. And the study just summarized it nicely, where even in cases of enterovirus meningitis, the mean days of therapy for antibiotics is still about 3 days. Mean antiviral therapy is still about 3 days, and even antifungals is at 2 days. For cases of bacterial meningitis, there's still a mean antiviral therapy median therapy of 2 days and antifungals of 4 days. And herpes viruses, same thing, you're on antibiotics for another 3 days and antifungals for a median of 3 days. So there's a lot of work that can be done to improve the time to discontinuation of these unnecessary antimicrobial agents. And I think that's something that rapid diagnostics can really help assist in. So some of the things that we do to hopefully help reduce duration of antimicrobials is we call each result to the provider directly, in addition to reporting it in the electronic medical record. And what we found is that a virus that's detected resulted in faster discontinuation of antibiotics with about 1 day compared to a patient with a negative FilmArray assay. And when we broke it down to the actual bacterial positive versus the viral positive, for the bacterial positive, there were 8 of the cases where the antibiotic changed within less than 24 hours, which is what we'd like, so likely escalated or de-escalated in some way. No change was required in the remaining 3 patients. And then for the viral, about 75-76% of all the cases had antibiotics stopped within the 1 to 2 day mark, or mostly within 24 hours. And then the remainder the remaining 4 took greater than 2 days. And so one thing that we started just recently is also we emailed our antimicrobial stewardship team with this result, which includes myself, the infectious disease attendings, and pharmacy to hopefully help prompt changes much quicker. There was one study that was published in 2018 that looked at the cost effectiveness of offering the FilmArray panel in all patients versus in patients that had pleocytosis. And so they developed an economic model on an Excel software and looked at 3 categories: patients that only had standard of care testing, which is listed here, patients with FilmArray testing on all patients, and then patients with FilmArray testing only on CSFs that were considered abnormal. And they're assuming that the FilmArray pathogens would cause approximately 75% of all pediatric meningitis cases. and that about 97% would be accurately diagnosed by this panel. And what they report is that there could be a cost savings of about $13,000 per patient if all patients were tested versus strategically choosing who to test and who not to test. So that's a model that was developed. A Canadian study was just recently published looking at a group of patients that were offered standard of care testing only, where the HSV and the enterovirus PCR was sent out, and then a group of patients that had the FilmArray panel ordered on them. And what they reported, what they were looking for is the time to discharge, and they estimated that using regressional analysis. They reported a potential cost savings of about 2,300 Canadian dollars per patient, with a reduced length of stay of 1.5 days in the group that had the FilmArray tested. Interestingly enough, there wasn't the change or the difference in discharge time wasn't due to antimicrobial stewardship per se, but what they found is that the reduction in length of stay was due to the fact that the report was coming out much quicker with the FilmArray panel compared to the conventional method where they're sending out for HSV and the enterovirus PCR. So, just really, I guess, honing down to the fact that it is very important for the laboratory to report these out and to offer these types of rapid diagnostic tests, and that it does does have a positive impact. Okay. And then lastly, I just want to finish off with a few slides on the BioFire Syndromic trends software. So this is a cloud-based network that compiles real-time pathogen data from labs all over the world. So we've been online with this software for about 4 years now, I believe. And basically the great thing about it is this epidemiological tool that just monitors the prevalence within your institution as well as regionally. And I have an example of the next slide. So for example, this is a snapshot of what our data looked like in 2014 here. And this is during flu season, which is highlighted here. And so you can see as you're monitoring the prevalence of each target, there was definitely an uprise in RSV, an uprise in influenza, and so you can visually see this as well as have each number laid out for you within the software without having to do it manually. And you can compare it to regional data. So it's a really nice way to really monitor the prevalence within your institution compared to others. This is an example, because we're talking about meningitis, of meningitis data that we've looked at. So we looked at children's site-specific versus mixed population sites and the prevalence of each different target from each site, and the prevalence of each specific target. And this represents just the bacteria and the yeast pathogens, but of course you can do it for the viruses as well. And it's just a nice visual way, as well as it compiles the data for you to have a look at versus having it done manually, which is something that we used to have to do pretty much on a weekly basis before. So what I actually get is a weekly report from the BioFire Trends group that summarizes the positivity rate and the prevalence of each pathogen that we've detected on a weekly basis, which is nice. The one thing that really, I guess, sold me on the Trend software itself was in 2016, when we were seeing that the increasing levels of EVD68 and increased numbers of acute flaccid myelitis cases in our institution. And this was using part of the Trend software is a pathogen extended resolution test, where they can predict very accurately the presence of enterovirus D68 versus other rhinoenteroviruses. And this study here, that's summarized in this table, looking at multiple institutions, compared a real-time PCR assay for EVD68 against the per test from the Trend software, and the sensitivity was 91% overall with a specificity of 88%. So it was able to really predict that emerging pathogen, enterovirus D68, instead of having to do a manual test for it. This is an example of our data from 2016. So the red was the prevalence of EVD68 using the TREND software, and the black bars were the cases of AFM that we have identified and in 2016. So we definitely saw an association between the AFM cases with the EVD68 that was monitored using the TREND software. And then lastly, this was in 2018. We were monitoring EVD68 very closely in 2018. And so fortunately, we found that the levels of EVD68 in our institution was very low. So we ended up not having to reflex to a manual EVD68 PCR assay to monitor. In contrast, at Nationwide Children's Hospital, the TREND software basically alerted them of an increase in EVD68 in about mid-July, and that was when they reflexed over to a manual PCR assay. And you can see the red and the yellow compared the per software with the EVD68 assay, and it's a very tight, close fit amongst the two. So it can be a very helpful in early detecting emerging pathogens early, which can then prompt how you would reflex to an active surveillance within the institution. So in conclusion, so the FilmArray ME panel can improve diagnosis of meningitis and encephalitis caused by a broad spectrum of pathogens. Restricting the panel based on pleocytosis criteria may miss a variety of different positive true cases of infection. Preliminary data demonstrate that there is positive clinical and economic outcome. However, clinical studies are definitely necessary. Additional studies are necessary to really determine the impact of patients and hospital economics using these types of rapid diagnostics. And lastly, the Syndromic trends tool can be a useful epidemiological soft tool for institution that can monitor your current institutional data as well as emerging pathogens within the institution as well as the region. And with that, I'll be happy to answer any questions.
Thank you very much. Reference laboratories are a little bit afraid of these assays in the sense that they sometimes see that regional laboratories don't send the material then to them any longer, don't go cultures or do not forward the CSF samples for further typing and national surveillance. How do you handle this in your institution?
So, sorry, let me just make sure I understand the question. So for reference laboratories where the samples are being sent to the reference labs for additional testing, is that what you're saying? And
for Neisseria meningitis and Haemophilus, the organisms we are talking about here, it is important that regional laboratories send the material to the reference laboratories, which are usually national reference laboratories, for genomic typing, for other typing efforts that you usually don't do in your local facility.
So we do the same. So we have a positive, particularly in isolate, we do send out to our local public health laboratory, which will then serotype and subtype the strains. The one issue would be for the patients where the FilmArray detected, but you don't have a culture. So for those, our local public health lab has not really tackled this, and I think that is very important that we do. But however, we do have the opportunity to send the samples to the CDC, who will then, if depending on the case, will then subtype them as well. We had a recent VZV meningoencephalitis case, and we were trying to rule out if it was the vaccine strain or not. And so that was a sample that we sent to the CDC for typing. So we do have that option as well. But I agree with you that in some cases the public health laboratories and stuff really kind of have to, I guess, catch up to some of the clinical labs when it comes to these molecular technologies.
Yeah, thank you. Thank you, very impressive presentation. I wondered if you could comment as a microbiologist on applicability to low-income countries. I mean, apart from the cost, how is it? What are the what are the technical skills, the laboratory standards, the robustness of equipment, need for maintenance, those sort of questions. I mean, are they? Could you comment on that, please?
Well, I think the one great thing about the FilmArray panel, and so I come from a lab where we do a lot of lab developed tests as well for molecular. And the one nice thing about the FilmArray panel is because it's so simple that it almost is made for kind of the, I guess, less developed laboratories in the sense because you don't need those high complexity equipment, you don't need that skill set that's necessarily required for high complexity molecular testing, including the infrastructure, you know, like a pre and post room, etc. You know, so I think that is a plus. The one thing to state though is that because it is still a molecular test, you shouldn't take it lightly. Because especially for the meningitis panel and the type of targets that you can have contamination due to respiratory flora, so that's something to take into account. So proper like PPE, you know, gloves, gown, etc. We handle all of ours in a BSL-2 hood, but my understanding is there are other laboratories that don't, and we're just probably being a bit cautious. Overly cautious since it is a CSF sample and we do handle all CSF samples under the hood anyways. But with regards to resources in that way and maintenance, it actually is much less maintenance compared to any of your higher complexity PCR assays.
So thank you everyone.